Okay, so any questions anyone has before I get started? Don't forget there's a sticky board I can look at during the break. If you guys have any questions you don't feel comfortable saying out loud. All right, nothing else? Fantastic. Let's go ahead and finish up and round out our wonderful survey course in epidemiology and learning how we can actually use this in the real world. How can we actually improve some of the decisions that we have in the clinical medicine? Now, why do we care about making good decisions? Or how do you think this might affect you? How do you think you can use biostats and epidemiology to help you make a better decision about your patients? You're like, we can't. It's just, this whole class was just used. No. I would tell you how, right? So again, we've already kind of looked at it a little bit. Like, remember we did the journal club yesterday. Like, we're looking at things like, okay, well, looking at hyperkalemia. Like, okay, well, what's actually going to be definitive therapy here? This article helps us to kind of guide us and show that, okay, patient might just need dialysis, right? And may have a lower threshold in order to, call that nephrologist, right? What do you call that when you make a decision based on the evidence? Evidence-based medicine, right? It's a big deal because you want to make sure the things you're doing are not just because I feel like it or just because anecdotally you feel like patients are going to respond well to this particular therapy. You want to make sure there's something to back you up, right? So that way, say for instance, you ever come into the court of law and they say, well, why did you do this for this patient? You'd be like, well, the guidelines told me to do that, right? Or the evidence says that this is the best course for my patient, right? And so this is what this whole course has kind of been gearing you towards, like learning how to read the medical literature, learning how to take those points and be able to apply it back to your patients. So you get to practice that evidence-based medicine, right? So anyway, and one of the other big things we'll talk about today as well is looking at things like how do you make your diagnosis, how do you use things like laboratory tests more intelligently, how you decide, when you're trying to make that decision of yes, you have this disease or no, how this plays a role. So anyway, again, being evidence-based means you need to be a lifelong learner, right? We always ask you about that during like the interview process, like, how do you plan to be a lifelong learner, or, all these things, and what does that mean to you guys? What do you think? Just mean doing your CME every 2 years, however long you have to do it for? No, it means actually staying up to date on the new articles, new literature that's coming out in your field, right? So for instance, I mainly look at the toxicology literature. I like to look at the big articles that are coming out because it helps inform me if I need to manage patients differently from one year to another, right? And so you need to know how to get access to the most relevant clinical informations out there. I can tell you if you can somehow maintain a university affiliation, that's a huge benefit is you actually get access to the library, right? So being able to go back and access the NOVA library, which is actually really good, and all the digital resources is awesome because you can go back through and look at, go through the PubMed, find all the recent articles. If you go into dermatology, you can stay up to date on all that stuff. If you go into emergency medicine, whatever, you want to be able to stay abreast of the current literature, and that's a really big help there. And again, learning how to look at that literature and deciding, is this trustworthy? Is this something I can actually take some information from? Or is it kind of just a study's no good and I can't really take anything from it, right? And so this is what this class is trying to gear you towards. And so one of the big things you may see being talked about is called Bayes' theorem. We talked about it very briefly in the introductory lecture many months ago, but this is going to be a way that we can use evidence and use things like the prevalence of a disease in a population, help us guide and decide, like, well, okay, if a test comes back positive, what does that mean for my patients? Does that mean they have a disease? Does it mean they don't have a disease? Bayes' theorem kind of helps out along with this. And so, had you watched the lectures that were assigned for yesterday, you would know a lot about sensitivity and specificity, right? And so that's actually going to be playing a big role here as well. Does anyone know what sensitivity is? So that's not like a poke you and you say, ow. Is that true? For sensitivity? Yeah, that's actually the positive one. So it says if you have, if a test comes back positive, what's the chances are that you actually have that disease, right? That's actually a true positive. Specificity, on the other hand, is what? The other one, right? So it's going to be the negatives, right? So if it comes back negative, then that actually truly is negative. And so this plays a big role because, again, if the test comes back positive or negative, you need to know what to do with that information, right? There's nothing worse than ordering a lab test that comes back with a number and you're like, well, I have no idea what to do with this, right? Because you don't know, should I make do I need to initiate new therapy? Do I need to make a certain referral? Whatever the case may be, you need to be able to kind of interpret these numbers, and this is where this can come into play. Yes, sir.
So we said sensitivity is the negative, right?
Sensitivity is being able to, when a test comes back positive, that means that truly is a positive test. It means it's real, right? Because again, we said if it's, if it's not a true positive, what is it? It's a false positive. And we would like to have as few false positives as possible. So when you go back and look at sensitivity, you're going to see that's basically trying to tell you what the true positive rate is versus the false positive rate, right? Specificity is just the opposite of that, looking at the true negatives versus the false negatives, right? Okay, and we're going to go into some more detail in here. We'll kind of see how that helps us out. Basically, what Bayes' theorem helps us to do is we take this prior probability. We have an idea of what we think is the actual incidence of disease in the case, or what we actually think of the chances are of this patient maybe having a disease, and then applying that, and then getting this kind of posterior probability to say how likely we are to think this patient actually has a disease that we're interested in, right? So, for instance, looking at, say, something like HIV has a fairly low prevalence amongst the whole population. Being able to take that information about the prevalence and then apply it to a laboratory test, so when a patient comes back HIV positive, you can have some degree of assurance that yes, that is true, or maybe it's not true. And because again, do you want to accidentally misdiagnose someone with HIV? No, that could be pretty bad. Or how about if you miss HIV? That's also very bad, right? So these are where Bayes' theorem can come to play here. Basically, when you do the math, and you should be able to do this on the test, right? Just kidding, you don't need to do that, right? But basically what this is telling us is that when a test comes back positive, whether or not that patient really has the disease, right? So when you see D positive, that means that the disease, they actually have the disease. The T positive is that the test comes back as a positive. So that's what's really kind of trying to tell you is that when the test comes back positive, what's the chances of they actually have that actual disease? And when you go back and look at those lectures from yesterday, you're going to see that when we talk about positive predictive value, this is going to be playing a big role here as well, as we'll see. And again, we're going to go into some more details. So again, the math is complicated. You don't need to be able to do the math, right? You just need to be able to kind of understand the concepts of what's going into this. That way you can kind of understand what's coming out of it, essentially, right? So again, does everyone know exactly how your laptops work? No, but you know what to put into your laptop to get something to come out of it, right? You don't need to know how the actual processor's working. You just need to know that if I put in this information, here's what I get out of it, and that's when you can do something with that, right? And again, a lot of people just say, it looks too complicated, I'm not going to do that, and just throw in the towel. It's not the case. We can actually find that it's actually a little bit more simple than what it looks like. And again, when you talk about positive predictive value, this is basically what we're using. So looking at something like, a disease that has, say, a low prevalence in it, you're going to find that even when you have a test that has relatively high sensitivity and specificity, you're still going to have a pretty high number of things like false positives that are showing up. And so again, we just know that's going to be inherent to any given test based on that. And so by having an idea of what the actual prevalence of the disease is in the population beforehand, this gives us a better idea of what the actual rate of those true positives and false positives are going to be as we go forward. And I'll show you some examples of this in just a few seconds. But again, it helps us to guide things like, do we do screening programs for everything? Like, do we need to test every single person for a particular disease state or not? A lot of times, things like Bayes' theorem is kind of helping us to make that decision there. And so it can help from like a cost effectiveness sort of standpoint. If you remember, there's an example back towards the beginning of the class where they said they were going to check every single newlywed couple for HIV, right? And they found that it was very, very expensive to initiate that program, and there's so many false positives, right, that was causing you to have secondary tests being run, that it was really not even worth it, right, because the prevalence of that disease was so low in the first place that it was very rare that you actually found anyone that actually had the disease that didn't know about it already, right? So again, this is where we're looking at things like prevalence of disease as being the prior probability is going to be something we're actually putting into the problem in order to get an idea of how likely we are to think that the patient really has the disease when that test is positive. Again, here's an example looking at something like a tuberculin tine test. This is an older way we used to test for TB, basically, where you'd have these tines you actually poke into the patient's skin that had some tuberculin protein on it, and then looking for that inflammatory reaction, say 2 days later, you could say whether or not the patient had TB. And so basically looking at this, we're going to need information like the sensitivity, we're going to need the specificity of the test, and then the third piece we need there is that prevalence of disease beforehand. So you want to have a good idea of what the actual prevalence of TB in the population is that you're curious about going into the problem here. And basically it will tell us that the probability that if a patient comes back with a positive inflammatory reaction to that tine test, what are the actual probability they really do have that disease, okay? Again, you obviously want that number to be high, so that way if someone comes back positive, yes, they have it, and then hopefully if they're negative, they also don't have it, right? So let me show you how the calculations were made. Basically, let's just suppose that this test has a sensitivity of 96%. So that means that if I tested 100 people with the disease, how many of them would show positive? 96 of them, right? That means that I would have 4 people that tested negative. What do you call those? They actually have the disease and they tested negative. It's a false negative, right? So again, so basically that's what that sensitivity is telling us, that those 4 patients would be considered false negatives when really they actually do have the disease. And looking at specificity, let's say I ran a test in 100 people who did not have the disease. 94 of them would test negative, and then I'd still have 6 people who tested false positives, right? So again, keep those concepts in mind about what sensitivity and specificity are actually telling you, okay? And a lot of those tables in some of the previous lectures, when you go back and look at that, will give you a good idea of what that actually is. But let's say, for the sake of argument, that our prevalence of tuberculosis in the community, we estimate to be about 1%. Now, are we always going to have an absolute concrete number of what that percentage is? No, but we can kind of estimate it, right? And again, that's where things like surveillance systems and things like that can help us get an idea of what that is. And so going through the math, we'll see that only 13.9% of patients who have a positive test result are actually likely to be infected with tuberculosis. Does that sound like a pretty good test? If you show positive, 13% of the time you're actually going to have the disease? No, because there's going to be a lot of false positives there, right? And so I'll show you the math on how that actually works. And again, this looks more complicated than it is, but let me just work you kind of step by step through this, right? So first off, we need to know what the beginning data is. So what we need first is going to be the sensitivity of the test. We already said that was 96%, which you can basically just turn into 0.96. We know the false negative error rate is 4%. Does that make sense why we got that false negative error rate of 4%? Because basically these two numbers together should equal 100%, okay? Because if you're not a true positive, then you're a false negative, right? And then looking at specificity, 94%, so it can be converted to 0.94. We have the false positive error rate, and again, these two together should equal 100%. Makes sense based off what we just said there. And then you want to know the prevalence of disease beforehand, okay? And so basically what you can do is by taking that prevalence there, and again, looking at 1%, if I had 100 people in a room, how many of them would I expect to have TB? Just one person, right? This is 1% prevalence is what I would expect. So I can take that information and plug it into this theorem here. Then again, you don't need to be able to actually produce this math here, but when they get these numbers coming out, it's important to know. Another thing to note here is this prevalence in the population. This is the prior probability. So again, if I had 100 people, I would expect one of those people to actually have tuberculosis. Okay, it's prior probability. What I'm going to get at the end of this is going to be what we call the posterior probability when all the math is done. But let's see, we're actually going to be able to plug all this into a 2x2 table here. And so basically you're going to say, okay, well, if I have, say, 10,000 people as my total, again, this is just kind of fictitious numbers here, but let's say we have 10,000 people, and we said the prevalence of tuberculosis in the population is 1%. How many people should actually have the disease? So just move the decimal place over a few spots. You get 100 people, right? 1% of 10,000 is 100 people. And so that's where you actually have people who actually have the disease in this column here, 100. Okay, see how that number goes there? Or why we get that number there? And then for the other 100 subtracted from that 10,000, we have 9,900 people left. Okay, so those are all actual the true negatives there. Okay, so these are all the non-disease people. These are all the people with the disease. Now, if we were to subject those patients to the test, given what we know about the sensitivity and specificity, we actually would end up seeing that of those 100 people, we know that 96% of those people with the disease should show positive, right? We know that 4 of them would be false negatives, right? Similarly, looking at the non-disease individuals, you can see here you'd get this rate where you'd have 94% of those individuals showing up as true negatives, but you'd have about 6% or 594 people showing up as false positives. So that means that when you actually take this information here, that you're going to get all the people that show positive, what was the actual percentage of them that actually had the disease itself? When you do that, you find out it's only about 13.9%. So it's saying that of all the people who had a positive test, what percentage of them actually had the disease? And you can see here that's a pretty low number. And again, it's not good if you have a test that comes back positive, you only have a 13% chance to actually have the disease. It's not a very good test, okay? But we can use this as part of a screening tool, right? We can use this to kind of guide us towards maybe the next test, and we can actually use this number again as the prior probability for the next test we're going to run. So we're going to talk about sequential running of tests in order to try to get to a point where you come in actually to a definitive diagnosis, okay? Everyone kind of with me so far? Probably not, but go back and review the videos. For the test on Thursday, you will definitely have it, right? Fairly confident of that. So again, you're going to see there's going to be a considerable number of false positive cases that actually do not have the disease there, right? If you were to actually run the numbers to kind of, again, simulated, but using that sensitivity, specificity, and that prevalence in the population, like that's what we need to actually come up with these numbers here. And so basically you'd find that especially when you're running programs for a long period of time, you may do the first test and you have all these false positives, and you go do subsequent tests, and you can say, okay, well, now we find out that actually only that 13% actually had the disease. That's all well and good. Sometimes when you're doing a second round of screening, oftentimes you're going to be finding people who may have not had the disease, but actually contracted it somewhat at a later time, right? So, for instance, with the first round of screening, sometimes you're catching people who've had it for a really long time, or sometimes you're catching people who just got it recently. By doing that second round of screening, you've already kind of found all the people that have had it for a long period of time, and you're just getting the new cases that are there. So sometimes you'll see by doing multiple rounds of screening, you can get a better idea of who's actually developing the disease over time. So instead of just looking for prevalent cases, you can now look for kind of new incident cases as time goes on. But so let's say, for instance, we're a clinician, we're really uncertain about a patient's diagnosis, and then we get a positive test result back for a disease, right? And again, do you just want to take one test and just say, okay, it's positive, you have the disease? Oftentimes, maybe not, right? It depends on the actual test you're going to be running there. But if you know the sensitivity and specificity beforehand, it does help you out, because knowing that prevalence of the disease in the population, knowing the sensitivity and specificity, you can start to get some of those numbers there. We can apply that with Bayes' theorem. But again, sometimes it's not even just the prevalence of the disease. You may not have that information. Sometimes you're just saying off of what you think is the chances, right? A patient comes in with certain constellations of signs and symptoms. You say, I think there's probably 75% chance they have this disease. That can be your prior probability too, right? So it just depends on what you want to put into that equation there. So let's say, for instance, we have a patient who is coming in and complaining of this easy fatigability. They have this history of kidney stones. They don't have any other signs of parathyroid disease. We're kind of focused on parathyroid disease right now. And so let's say you are thinking about the patient. Okay, what is the actual chances this patient has hyperparathyroidism? Okay, you say maybe it's pretty low, probably 2% chance that they actually have that disease. Okay, we have no idea. Now, what's an easy test that we could run to see if a patient has hyperparathyroidism? Run for calcium, right? So if the calcium's high, that gives us an idea that may have the disease. And if it's low, then that would probably tell us no, it's probably not the case. There's probably some other reason for him to have these signs and symptoms. So anyway, so what we could do is we're going to be using tests with high sensitivity early on to try to rule things rule things out, and then we're going to be using tests with high specificity to rule things in. Okay, so you guys remember spin and snout? You want to see that in the lecture previous, perhaps? When you go back and review that, that's going to be a really important point there, right? So we're going to see the test with high specificity rule things in, tests with high sensitivity help us to rule things out. We'll get into more details on that in just a few minutes here. But so what we're going to do first off, we're going to use something like calcium. Now, if calcium is high on a patient, does that absolutely mean they have hyperparathyroidism? No, there's a million reasons you get hypercalcemia, right? So again, it's one of those things where just because it's positive doesn't mean that patient has that disease. So it's not going to be good for necessarily saying that yes, they have hyperparathyroidism or not, but it will give you that clue to maybe go on to the next test. Well, maybe I want to go check say a PTH level. PTH levels are more expensive, they're harder to do. So that's why this can help us with kind of more economical use of our resources, to start with the easy test first. And if it's positive, then it'll kind of lead us to maybe using the more expensive tests or more difficult to run ones later on. But let's say, we're going to start with the serum calcium. This is going to help us to rule out the diagnosis. If it comes back normal, then we can say, okay, it's probably not hyperparathyroidism. We can move on to looking at another diagnosis, right? And looking at another differential here. But let's say it comes back and the actual level is 12.2. And we'll say that's high. Okay, we'll say that beats our cutoff. As I'll say 11 is a normal high for calcium. Guy comes back at 12.2. So at this point, what do? Well, we can actually use Bayes' theorem to help us out to decide, okay, well, before we thought this patient had a 2% chance of having hyperparathyroidism. Has that gone up now? It has, because we have a high calcium level. So we want to figure out, well, what do we actually think is the percentage likelihood this patient has it now? And so that's where Bayes' theorem can help us with that. So basically what we're going to look at is looking at the test for calcium. We see that it has 90% sensitivity. Is that pretty good? Now, you really want high 90s whenever possible, but I mean that's trying to tell us that there could be a lot of patients who have a high calcium, but it's not necessarily due to hyperparathyroidism. So we'll only say 90% sensitivity here. I'll say 95% specificity. Okay, so now we have our prior probability, that 2% that we thought was the likelihood that patient has hyperparathyroidism, and now we have the sensitivity and specificity of that calcium level. And now we can plug it into Bayes' theorem. We'll get that 2x2 grid going again, and it'll give us an idea of what we now think is the likelihood of that patient actually having the disease. Again, we're just using that positive to help us out with that. So again, looking here, we're going to see that the sensitivity is 90%, the specificity is 95%, as we saw in the last slide, and we had that 2% prior probability. And again, that's not saying that it's a 2% prevalence in the entire population. We just said that was what we thought it was beforehand. Yes, sir.
Just to sum up what you said, Bayes helps us determine if the probability of something is true.
Mm-hmm.
Just Yeah, that's the summary of it.
Basically, yeah, no, I'll show you that just in a second here to look at this. So again, it's getting that prior probability and seeing if we can get that even higher, right, to actually make a definitive diagnosis for something. So when you actually look at this, if you actually plug in, let's say we're just going to use 1,000 people as our total we're putting in here. Again, if it's a 2% chance we think patients might actually have it, we use that 2% of 1,000. That's where we get 20 people here, right? And then we have 980 left over that are going to be people who actually do not have the disease. So basically, you run the numbers the same, and basically when you end up getting out, what you get is posterior probability. So because that patient had a high calcium level, your suspicion for hyperparathyroidism has gone up, and so it went from 2%, and what's it at now? That's at 27%. So now I think, okay, well, I'm still not completely convinced the patient has it because there's a lot of reasons for hypercalcemia, but I'm more convinced now than I was before. It went from 2 to 27%. Okay, so this kind of raises it up on my level of suspicion. Now I can maybe do another test, and what you're going to find is that the new prior probabilities is going to be that 27% now, right? So it's a sequential thing where I'm going to get higher and higher likelihood, and when I get pretty close to say 99 or 100%, then I can definitely make that diagnosis. Okay. So again, this is just telling us that that test is positive. What is the likelihood that we think that the patient actually has a disease? Okay. So now we said, okay, well, we went up to 27%. Still not totally convinced here, but we're more sure than we were before. And again, this will at least lead us to the point where we say, okay, well, maybe before I just don't want to get a PTH level on every single patient that comes in. But now that I have this higher index for suspicion, I'm going to go ahead and order that PTH level. And then now when I get that result back, I can now get a new posterior probability again to say, well, okay, well, if that comes back positive, what's my likelihood of actually thinking this patient has hyperparathyroidism? So again, it's helping us make better decisions about what kind of lab tests we're going to be doing here. So we're going to find that when you do a parathyroid hormone level has a sensitivity of 95% and then a specificity of 98%. Typically, what you're going to want to start with are tests with very high sensitivities, and then you're going to move on to getting tests with higher and higher specificities, right? Because we're going to use specificity to rule things in. So start with high sensitivity and then move on to higher specificity. That's what we're doing here. So now that we have a new prior probability of 27%, we now have a sensitivity and a specificity. We can use that to then run the numbers again to see how likely we are to think this patient actually has hyperparathyroidism. Running the numbers again, you can see here that our 27% of that 1,000 is going to be included here. So this is be the fictional number of people we think would actually have the disease versus those that don't. And when you actually run it through, you're going to find that positive predictive value. If that patient has a positive PTH level, now I'm 95% sure. Which makes sense. PTH levels are high. Patient probably has hyperparathyroidism, right? Stands to reason. So again, we didn't start off with using that more specific test. We started off with something as more of a screening tool. You're just using a simple calcium level that's easy to get, and then moving on to something that's more expensive, right? Again, that's more judicious use of your lab test than just kind of blasting everyone who comes in with these signs and symptoms getting a PTH level, right? Someone's going to come back and actually be like, well, why'd you order that? And you want to have a justification for it, right? So again, that's where I say, well, because the calcium was high and then I had a high suspicion, so I went ahead and got the PTH level, right? Everyone with me so far? Still? Okay. So again, why did the posterior probability go up so much that second time, right? Because if you saw, we went from 2 to 27%, and it went from 27 to 94%, right? There's a big jump there. And the reason for that is because the specificity for that second test was so much higher, right? And because we have a high specificity, that means you have a very low false positive rate. And so when you have low false positive rates, that means that when the patient's actually positive, that means that, yeah, it probably is an actual truly positive result there. So again, it goes in to show you that specificity helps us to rule things in. That's how we actually make that final diagnosis there, right? So again, start with tests with high sensitivity just as a screening tool. You're probably going to get a lot of false positives there. That's okay. And then as you go forward, you're going to get more and more specific tests. And then when you get that final diagnosis, you can say, yes, I'm pretty sure this patient has the disease I'm looking for, right? So, and again, you're going to find that a lot of times patients or providers will just go ahead and order every single test all at the same time, and then you end up getting all these results back. And sometimes it's hard to parse through and to say, okay, well, what is it really telling me? Because some are positive, some are negative, and you don't really know always what to do with it. But by starting with those tests that have the high sensitivity and kind of using those as your screening tool, and then kind of moving forward with more specific tests, it'll give you a better idea. And again, a little bit more judicious use of your lab test. Of course, again, when a patient comes in to say the ER or the clinic and you want to order labs on them, do you usually order one lab at a time, and the next one, and the next one? You're going to find that a lot of times that is not practically done. However, when you're doing things like more specialized tests like a PTH level, something like that, you want to have a higher index for suspicion, so sometimes that it'll make a little bit more sense in those cases. So anyway, again, as I mentioned, the sequential approach, you want to use tests with high sensitivity first, and then move on to getting more and more specific tests as you go forward, right? And again, high specificity helps us to rule that final diagnosis in when they do come back positive there, okay? Okay. So again, looking at the sequencing here, note that a lot of times when you have those multiple tests all being run at once and you get all the results back, sometimes it's easy to try to, just look at the ones that come back positive, just look at the abnormal results and say, okay, I'm just going with these, and ignoring the ones that are going to be that were considered normal, right, or the negative test results. So it's important to make sure you kind of take the whole picture into account. You just don't want to go and just hang your hat on just one specific thing and say, yep, this is my diagnosis, when maybe the test results didn't actually kind of bear that out. But again, if you can, try to look at the ones with high sensitivity first and then move on to the high specificity. Okay, so again, the whole purpose of this is because when you have a patient come in, there's a lot of uncertainty. You have no idea what the patient actually may have based on their signs and symptoms, and so this decision analysis helps us to kind of get a better idea of what we should actually do for a patient, what's actually going to be best for them. And so instead of doing Bayes' theorem, we actually can come up with these decision trees, and this is actually done pretty frequently, where you have a patient, maybe they come in, we're going to use asymptomatic gallstones for our example here, and you say, well, okay, well, do I send the patient to surgery or do I not? How do I make that decision, right? Because again, every single course you could take, whether it be nothing at all or whether it be surgery, all have risk associated with them, right? And so these are where decision trees can kind of help us out with this. And so you're going to find that these get used pretty frequently, and especially if you go and work in places like ERs and things like that, everything is very algorithmic, right? You have a lot of decision trees being made that, hey, if the patient has this, then you're going to go down this route. If they don't have this, then you go down this route. And so these decision trees kind of help out quite a bit. So, and again, you're going to find that some of the information you're going to need here is that you need to know kind of what information is going to be going into making your decision analysis. You need to kind of know what the sequence is going to be when you're actually making these decisions. And then also kind of consider, what's the personal values for the patient, right? If the patient's really worried about a specific outcome or a specific side effect or something like that, it can change the values a little bit of how much they kind of weight that alternative, right? And so again, that's why it's a very personalized sort of thing. You need to kind of have that conversation with the patient about. Anyway, so I'll show you an example of what these look like in just a minute. Kind of help us, it can help us to guide us to decide, what's going to be best for our patient. Okay, so again, there's going to be 5 steps that are going to be here when we're doing a decision tree. One, you want to kind of identify and set limits to the problem we're actually looking at. So you want to kind of keep these limited in scope whenever possible. We'll diagram out the options. I'll show you what that looks like in a minute. Obviously, you can obtain information concerning each of the options, kind of what are the outcomes that are associated with that, what are the chances of our patient experiencing a particular outcome, and then we'll look at some of these utility values and then perform sensitivity analysis. We're going to go through this in more detail, and so we'll kind of look at what that means in just a moment. Okay, so when looking at this course of action here, we're going to see that we wanted to determine kind of what are all the possible alternatives and then what are the outcomes that can happen from those particular decisions there. And so again, the problem we're going to use here is going to be these silent gallstones or asymptomatic gallstones. And the decision basically being, do I send the patient to surgery or do I not? Okay, so we're going to see what could be associated with that. So basically, what you're going to find is that the beginning point of the decision tree is starting off with the patient's clinical status, and you're going to have what they call these decision nodes, where you decide, say, surgery, no surgery, right? Medicine, no medicine, whatever the case may be. And then you're going to have these chance nodes. What are the chances of a patient going on to experience this particular outcome? We'll see that time's going to go from left to right, so we'll start at the left and kind of move forward. And so again, the beginning point here for our case is going to be this asymptomatic gallstone. So you've discovered this, you've made this diagnosis, and again, the decision is what am I going to do about it from here on out? So here's the tree, and basically what this is saying is here's our decision node. You say, okay, do we want to operate now, or do we want to go ahead and wait and see what happens? Okay, so with the operate now, we say, okay, we're going to send them to surgery. What are the chances that they're actually going to have surgery? It's 100% because I said, yeah, they're going to go to surgery, right? So we say, okay, that's it. And we're going to see the outcomes that we're looking at for this particular case is going to be probability of death. The patient's really worried about dying from surgery. They say, okay, well, what's the probability of that actually happening? With surgery, it's going to be pretty low, right? 0.4% chance that patient will actually die during that surgery, right? Is that a 0% chance? Can you say, don't worry, you're not going to die from this? No, you can't say that, right? So again, anything could happen. Probability is very low, but again, patients may say, well, that doesn't sound very confident. You said there's still a chance, right? Anyway, just like the lotto, there's always a chance. It could be me, right? But anyway, so then the other decision would be to wait, okay? And so now you have this chance node. There could be several things that could come about from this. And again, this all goes into the clinician, how they decide to lay it out. It could remain asymptomatic, right? And they say, what are the chances of it remaining asymptomatic? A lot of this is based off the literature and things like that. They say, well, probably 81.5% of those patients will remain asymptomatic. Nothing's going to happen to you. The chance of death from that is going to be 0. That sounds pretty good, right? Other things could happen though. It could say, okay, we have some biliary pain, maybe 15% chance of that occurring, and then the chance of that leading to death, pretty low too, right? 0.4%, probably not going to die just from that. Okay. You could have some other complications that show up here, maybe a 10% chance of death. This may occur in 3% of the patients who were just kind of did a watchful waiting sort of approach. And then finally, the worst outcome could be cancer. And let's say there's a 100% chance a patient will die from that. But again, only half percentage chance of that is actually going to occur. Okay. So now the question is, okay, you lay it all out and you say, well, what do I do? Do I want to send them to surgery? Do I not? Basically, what I can do is I can take all these chances here, all these probabilities, and basically by accounting for the weights of how likely each one of these are to occur, I can kind of come up with a little bit more of an apples to apples comparison of saying, well, what are the actual overall probabilities of death from not going to surgery versus going to surgery? And so by comparing those, you can then say, okay, well, I think surgery is going to be the best option for you because this is actually, you have a lower chance overall than if we just did nothing about it, okay, or whatever the case may be. So when you're doing this, and again, this is talking about the different weights that are going to be associated with the waiting process here. So again, 81.5% chance nothing's going to happen to them. They will not die from that. And just know that all the outcomes from a chance node should equal up to 100%. So again, if you added all those up, it'll be 100% there. So you also have to figure out what the utility of each outcome is going to be. And again, utility can be anything. It could be things like, years of life added on. It could be, years of work missed. It could be, cost. It could be lots of different things. And so that's where you have to have that conversation with the patient there. Utility could be things like disease-free years. Obviously, if they have larger values, they should have more utility associated with them in those cases there. So, and again, our goal here is to try to maximize the decision, whatever we make, to try to maximize the most utility for our patient. In this case, when we're looking at the asymptomatic gallstones, we're concerned about the lowest chance of death. That has usually more utility to it than being dead for most cases, right? Probably. Anyway, unless the patient was really suicidal, maybe, and then that would be less utility. I don't know. Who can say? Anyway, so again, looking at this, we're going to find that we're actually looking more of a negative utility. So this is something we're trying to minimize if possible here. So again, probability of death. Again, you can go through and look at those values that were there. Again, low probabilities for a lot of them, but when you saw like cancer, even though cancer was very unlikely to occur, death was much more likely to happen if it did happen, right? And we can try to combine those two probabilities together to get an overall feel like what's the overall mortality going to be associated with just waiting. And so you're going to find that hopefully the decision tree will give you a very clear benefit of one versus the other. Say, yeah, we should definitely do this. A lot of times there's going to be a lot more gray associated with it. You may not be able to come up with such a clear-cut sort of option there. A lot of times, though, you need things like better data to include, kind of feed into it. Better data you have, the more likely you are to make a good, robust sort of decision for your patient there. And then we'll talk about sensitivity analyses and how we can kind of fudge with those a little bit in just a few minutes here. So, as I mentioned, when we do sensitivity analysis, this is basically where you can change the numbers a little bit and maybe feed in different data sets or just change it a little bit just to see if the results are still the same, right? So again, if I change some of those values there as far as like how often people remain asymptomatic or the risk of death associated with the cancer or whatever, do the results still show up? Do they still show a benefit for one versus the other? By doing that, by performing sensitivity analyses, it makes you a little bit more sure of the choice you ended up making. So yes, I'm pretty sure that this is absolutely going to be the right choice for the patient here. So that's one thing you'll see whenever you see sensitivity analyses, is what they're doing. Okay, so again, in the decision tree here, again, we had either operate now or we had wait. And so we looked at the probability of death from operating being 0.4%, very low probability of that actually happening there. And then when we actually factor in the weights of all the different outcomes from the decision node, and you combine all that together, basically you get this value of 0.009. So that means that the risk of death overall from waiting was a little over twice of what it would be when you go, as opposed to going to surgery. So in this case, what would you decide for the patient? Probably say go operate, right? So let's go ahead and send you to surgery right now. Now again, mortality is not always going to be the only thing you're going to look at. There could be other decisions playing a role there. But this is just one example of how you can use the decision tree to say, well, based on the odds, and again, it's not just based off your gut feeling of like, well, you should probably go to surgery. It's saying, okay, well, I think based off these odds here, it actually says like you're probably better off going getting surgery now, and you don't have to worry about any of these other really bad complications down the road. That makes sense? So again, by doing those sensitivity analyses, you could change the numbers a little bit, maybe modify it to see okay, do I still get twice the risk of death by waiting or not? And by looking at that sensitivity analysis may kind of lead you versus one way or another based on how those numbers change there. Okay. So other things to look at. So factors, you know, as I mentioned, other than probability of death, probably should factor in here, right? So for things like, it may not just be death from the surgery itself, or maybe it could be complications from anesthesia, it could be cost, it could be lots of different things that could be involved here. But again, it's good to look at different outcomes in order to help you make your decision as whether to do it or not, right? And so again, looking not just at mortality, looking at the cost, maybe it's better just to wait. Maybe it's better not to do anything for the patient at that point. But again, you know, it's not always good to just go with the most aggressive thing possible. Sometimes it's good just to do the watchful waiting based on several different factors there. Okay. So again, other things where you can see an application of this. So for instance, you know, say hepatitis B vaccination, you know, we can do different decision trees to see like what's the best option here. Should I maybe just not do routine hepatitis B vaccination? Should I only apply it after a screening program to find people who are at big risk? Or should I maybe give it to specific populations? By running the numbers through these different examples, you can try to figure out, okay, well, what do I get the most utility out of this? Obviously, the biggest utility would be not getting hepatitis B, or maybe getting other complications from that. And so by using these decision trees, it lets you say, okay, well, maybe we should probably just go ahead and do it for these specific populations. We get the most utility out of that by preventing disease in those patient groups. Okay. So that's it for kind of the decision-making process. One other final thing we'll talk about here is called meta-analysis. Anyone know what a meta-analysis is? Anyone? You guys are familiar with the term meta? It's in the millennial vernacular, I believe. It's a really meta kind of comment. Kind of broke the fourth wall. Anyone? Okay, maybe I'm just running the wrong circles. Anywho, so meta-analysis is basically where you're taking multiple disparate sources of information, usually different studies, kind of pulling them together to give you a better idea, specifically about how to manage a disease, or you know, what are the chances of something occurring. It can be helpful for anything, right? Has anyone ever heard of the Cochrane Review database? You should get familiar with it. It's very good. If you ever hear about it, it's basically this big organization. All they do is meta-analyses. All they do is they pull different studies together to say, well, what's the best thing? You know, what's the best way to diagnose a PE? You know, what's the best treatment for acute otitis media? They do it for everything, basically. And so these can be very useful because, again, a problem with a lot of the studies that you run into is that very low patient numbers, right? So again, if your N is very small, do you have the power to actually find true differences in those studies? No, usually they're underpowered. They can't really find differences. However, if I can pool all that information together, say from 10 different studies, and now my N is much larger, I'm much more likely to find a true difference. And so again, it's not perfect. However, it's very useful to try to get multiple sources of information together to give me a better idea about what's the best decision, you know, for my particular patient. Because again, it's always about taking information from the population, trying to apply it back to your specific case you're using it for. And so, again, this is just using multiple trials or multiple studies, pulling all that information together. Now, what do you think are some of the potential issues of doing something like that? Are all the studies run exactly the same? Do they all collect the same exact data? No, there's what we call heterogeneity to the studies. We actually find that based on the differences between the studies, it may be hard to compare them together, right? Maybe it's much more of an apples to oranges kind of thing than it is purely just apples to apples. And so because of that, there are some inherent limitations to it, but they can still be useful tools to give us an idea of kind of overall, out of all the literature that's been done on a particular subject, what's out there? You know, what do they actually say when you actually pull the data together? Now, again, you don't want to use them just as your final say on, you know, what to do for a particular situation, but they can be very useful because, again, the gold standard is what type of trial? To find true cause and effect analysis, randomized controlled trials, right? And as we mentioned, is it always possible to do randomized controlled trials? No. For instance, we're looking at things like hyperkalemia. I can't just not treat someone's hyperkalemia and see how they do, right? Due to ethical concerns. However, you know, it's hard to do a randomized controlled trial like that. But what if I took several different studies that are all looking at treatment of hyperkalemia and ED and pulled them all together? That's still a little bit better strength of evidence than you would be just looking at, say, one study with 200 people in it, right? So anyway, there are some concerns, and there's different methodologies on how it actually comes. There's two different types you mainly will run into. One's more of a quantitative or pooled meta-analysis. The other one's we call methodological or methodologic qualitative meta-analysis, right? So quantitative, what do you think we're doing with that? With a pooled meta-analysis? Basically just kind of throwing all the patients together from all the different information and seeing what the results come out as, versus the methodologic ones, or the qualitative, are more looking at the actual quality of the studies and actually grading them based off of that. So we'll go into more detail. As I mentioned, the main purpose is to be quantitative with a pooled analysis. So I'm basically just taking all this disparate information, trying to get the same bits of information, because again, every study will do it a little differently, combine it all together to see if I can come up with a new risk. So you can come up with risk ratios, you can come up with new odds ratios. And again, you may have had, say, 2 different studies that were underpowered to find a difference, but when I put all that information together, now all of a sudden it is powered, and say now I do find a difference. Now, it's not as good as if I just did a brand new study, but it's a heck of a lot cheaper and easier to run when I can just kind of compare these 2 studies together, right? Put them together into the same pot, basically. So again, it's hard to come up with the specific answers from these, but again, it gives you a little bit better strength of evidence than if you just had those 2 disparate articles by themselves. And a lot of times we do what we call sensitivity analyses to them as well. So for instance, if you had, say, 10 different studies, you were doing maybe only including the ones that had the large patient samples sizes, or maybe only including the ones that are only done in this particular area. By changing it up and how you're kind of viewing it, you can see how the results change. And again, if they all basically say the same thing, no matter how you change the numbers, then that should give you some strength of evidence to say, yeah, this is actually true, what they're saying here, right? With the methodologic ones, it's more of looking at, okay, how would the actual studies perform? Like, were they actually good studies? Were they bad studies? When I say a bad study, what do you think that means? Like their methods weren't very good, maybe their inclusion exclusion criteria were not very good, maybe they didn't randomize, or they didn't blind, or all these different things that we consider a study bad, versus say really good randomized controlled trials that were double blinded, all these different things. And so that's what they can do. These researchers will go through and they'll kind of look at the actual quality of the study, and they'll say, we'll only take the really good ones, put them together and see what the actual evidence says, right? To say whether this is the best treatment for acute otitis media, or this is the best treatment duration for pneumonia, whatever the case may be, right? And so again, a little bit different flavor there between the 2, and they're doing 2 different things, but they can both help you to kind of pull the disparate information together and give you an idea of what to do for your patient. Okay. So for instance, looking at a meta-analysis that was looking at this BCG vaccine, it's used to vaccinate against tuberculosis. Say for instance, they found 3 trials that met all of their criteria for what they considered a good study, and they found that, yeah, all of them agree that the BCG vaccine prevented tuberculosis in those patients. It was a good vaccine. Whereas if you were to take the 5 studies that were very poor, maybe small sample sizes, they all were kind of, maybe they had, larger confidence intervals, maybe they had weaker methodologic, or the methodology was a little bit weaker, they would probably find pretty weak effects, saying like, okay, well, maybe the vaccine works, maybe it doesn't. But by excluding those and just looking at the really good studies, you can say, yep, this vaccine definitely does work for these patients to prevent tuberculosis. Okay, so that's kind of the main thing with the methodologic study. And so that's it for the last section. This is the end of the testing material for the epidemiology section of this class, right? Now again, the test is not cumulative. However, a lot of the concepts from the biostats section still are going to come up here, so they still apply. So just be aware. If you want to go back and review some of that stuff, that can be useful, right? So let's go ahead and we'll break up into our groups for the journal club. If you need to take a bathroom break or whatever you need to do, that's fine. Do that. Let's go ahead and meet back up here. Let's say at 2:50. I'm sorry, 1:50, not 2:50. That's too long. Let's say at 1:50. And then we'll go over the journal club, and then we'll do our test review.